Okay, thinning out for people to rush off to get onto the motorway, I expect. And so they're going to miss the opportunity of hearing Helen's talk, which I'm very, very pleased to hear, and I'm looking forward, because I think physical health care in our patients is often a topic that's omitted or passed over, because we tend to focus very much on the mental health problems. So Helen Walker, thank you very much for coming to speak to us. Dr. Walker is a senior lecturer at the University of West Scotland, and she's a consultant nurse as well at the Forensic Network. So she's very much in the world of firmly rooted in academia and also in clinical practice. Helen, please. Thank you.
Okay, good afternoon, and thank you very much for inviting me along to speak today. I'm delighted to be here, actually, and thank you for all staying. The durable group, well done. What I'm going to speak to you about today is really about why does physical health matter? It's fairly obvious, really, but also about what does the literature suggest, especially for the group of people we're working with, our patient population. I want to speak a little bit about the state hospital situation. We do an annual audit, so give you some feedback on that, and the steps we've taken to try and remedy the situation that we're in terms of the physical health of our patient group. Also, there are wider implications for the forensic network across Scotland, so I'll allude to that just towards the end of the talk. Can people hear me all right? Yeah? Just shout if you can. So when we're looking at, first of all, in terms of the importance of physical health, I guess it's embedded within the literature, but we know ourselves how important our physical health is to each and every one of us. It's one of the things we can understand probably better than any in relation to working with our patient groups. They may well have more severe and enduring mental illnesses, but they also, when we experience physical illness ourselves, we can relate that better. We probably have a better understanding and a better grasp of things, of how the patients feel. And the idea is that if your physical health is intact and good, obviously that's going to have one less thing for people to worry about. So it is a really, really important topic and an important issue, and we want to try and promote good physical health for everybody. And I think that's for patients and staff alike, I have to say, in terms of the environment, the hospital environment, and in the community. But when we look at the literature, we look at the stats are quite scary. People with severe and enduring mental illness. Now we're talking about our population, the majority of whom have psychosis, just the same as the people in your own organisation. They're at much higher risk of physical ill health. When you look at the mortality rates, at least twice of the general population, which is really quite significant. And the life expectancy is really quite startling when you look at because of people with serious mental illness, their lives shortened between 11 and 18 years. And that really is quite a startling figure when you start to look and the implications for people we're working with. There's also higher levels of cardiovascular disease, metabolic disease, diabetes, respiratory disease. There's also higher incidence of cancer, bowel cancer, and other forms of cancer. But there was one study, findings from another study in Italy by Clerici. They contradict the findings presented here in terms of cardiovascular disease, and they're saying that they didn't find any significant differences in the people in their population with severe and enduring mental illness by compared with the general population, and they attribute that to the healthy eating and lifestyle and support that's given from families in the Mediterranean population. When we look at why these things happen, what are the potential causes for poor physical ill health? As you would imagine, the genetics role, we inherit this vulnerability to the various different illnesses and diseases. So that's no surprise to anyone. And when we look at the lifestyle and environmental factors, they're really, again, quite striking. If you imagine the day-to-day life in, for example, a high secure hospital, forensic hospital, quite sedentary. People aren't really that active. Now, up until sort of fairly recently, people were smoking. Is it no smoking here across the whole hospital? So since when? What was the...
2008.
2008, so you're much longer than us. We've just managed it within the last few years. People tend to be overweight, and as I say, I'll give you the stats just shortly. And diet plays a big part. But this low levels of physical activity are a huge issue for many people. Also, the use of neuroleptic medication. I know we heard earlier on about olanzapine and maybe the stats are suggesting that people don't put on weight. Actually, there's quite a few of our people that are actually, it's the second highest use. It's clozapine's the highest drug that's used the most. Olanzapine's second within the state hospital, and there are quite a lot of large gentlemen, not solely attributed to that, but all of these other factors play a part. So in terms of what we tried to do to address this, Scottish Government took it in hand, and they took it upon themselves way back in 2006 to try and address the issue, especially for people with mental health issues. And they produced a paper, a policy delivering for mental health. And commitment 5 within that policy paper was to make sure that all people with mental health were offered at least an annual health check once every 15 months, rather than once a year, once every 15 months. That's what they made their commitment. Now, as I say, we can take a horse to the water, but you can't make it drink. We can offer this, but it wasn't. Not everybody wants to uptake their annual physical review. And I'll show you the stats later. Our current mental health strategy, this is the national strategy, we really want it's more based on health promotion and a preventative approach rather than the reactive approach that we've had in the past. And physical health is also built into the Scottish Recovery Indicator. I'm not sure if you maybe are familiar with that. It's the Scottish Recovery Indicator is a tool that's used to try and measure how well you're actually embedding recovery-oriented care into your organisation, whether it be on an individual or group or an organisational level. And they've built the physical indicators into that indicator, which everyone is supposed to be using. The other shift is really more a focus, and this is to do with the quality agenda in Scotland, to have patient-centred care, and it has to be safe and effective. So these are all the kind of things that we're promoting within the mental health strategy. There's a change and a shift in terms of the chronic obstructive pulmonary disease focus for self-management as opposed to other people managing things for you. And I guess that's linked into your recovery agenda as well. And also health promotion and cardiovascular disease prevention. So these are the main areas of focus within the mental health strategy. Now, the only thing that disappoints me about this picture, this is the State Hospital at Carstairs. A new build. It's one of the photographers, the press had taken this photograph from a distance, obviously. And I was trying to capture it for you to give you a kind of glimpse of what the hospital looked like. Now, we have four hubs within the hospital. So see these, call up the three here. These are hubs. You can only see 3 here, but there are 4, and they each have 3 12-bedded wards. Over the very far side, that's just a training centre, and that was the one building that they actually retained as part of the new build. Nobody knows why, but that's the one that was kept. So that's our state hospital, and the reason I'm disappointed here is because it's cloudy, because it feels like the sun always shines on the state hospital, but apparently they've caught us on a bad day. But never mind. The paper's for you. So in terms of what I would like to give you is a little bit of information about our state hospital patients, and give you some information on their physical health and their needs over the past year. This is current information. So we have, similar to yourselves, about 70% of people with primary diagnosis of schizophrenia or some other psychosis. Just about all on neuroleptic medication. They may be off for a short period or maybe for a period of assessment, but by and large, nearly everybody on neuroleptic medication. And your usual age range between 18 to over 60, average mean age of 42, and your average length of stay is about 8 years. Now, the reason that's so high is because you've got under 20 days to over 46 years. So that's a long spell, and obviously that's going to push your figure up. They should really have used the median, but that's what they use for their stats. And as I said earlier on, it's really, as you would imagine in a high secure environment, quite a sedentary lifestyle. I wanted to focus a little bit on nursing assessment because it's been just a different slant in things today. And our ward staff, when we're looking at how we contribute to assessing physical health, there are wider issues. But our nurses, if they're looking at assessing behaviours, they'll use Behavioural Status Index, and that was by Woods and Reed. They also use Psychosis Evaluation Tool for common use by caregivers, and that was based on Eva Lindstrom's work. I'll speak a little bit further about what they do in relation to physical health assessment, and everything is put onto electronic patient records, same as yourselves, which is really accessible and useful for being able to share information across wards when patients move from one ward to another. So when we're looking again from the broader group of nurses on the ward, they will routinely, on admission, people will get height, weight, body mass index, blood pressure, urine test, just the usual kind of things. But they also started using this nutritional screening tool. And I don't know whether you've heard of the MUST. Has anybody heard of that? It was a national screening tool that was used in Scotland. And so everybody it was decreed that everyone had to use this. But basically it focuses on people who are malnourished much more so than people who are overnourished or heading towards the obese end. So they adjusted the tool, whereas now most of the focus, so it's now called the Nutritional Screening Tool, the NST, its focus is more an emphasis on obesity and a lighter emphasis on the undernourishment. So they've just turned it on its head basically, but they have revalidated the tool. So obviously the other features that are monitored in terms of physical health are your sleep pattern, diet, personal hygiene, just the usual kind of bowel functions. That's when it's an issue, but they're also involved in physical activity. Then the Scottish Government did say that we all have to have a physical health plan. I don't know whether the same happens down here in England, but they stated quite clearly that everybody in every hospital, no matter where you were, had to have a physical health care plan. So we had to factor that into to our care. This is just a little bit more on the MUST plan, but I've already mentioned that, so I'll just move on. We also have, in terms of, we've got the broad nursing group obviously in the wards, but we've got an advanced practitioner who manages the health centre, Closbean Clinic. She provides a triage service on a Monday to Friday because her GP used to be there 5 days a week, but she no longer does that. She's only on the Monday, Wednesday and Thursdays. So in terms of having that 5-day cover, the advanced practitioner tends to take on a lot of these roles. And there is people can drop in for when it's like a minor ailment clinic, and she also does reports and reads the ECGs. So she's trained to quite a kind of sophisticated level, and that seems to work quite fine in the state hospital, in the high secure facility. But we don't have any such person in the medium or the low secure facilities. So we've got the luxury of this, and people do make good use of her. We also have an advanced practitioner, and it's actually a learning and development team rather than practice development team. And she links with a wider group of people, really mostly on relating to education, on bloodborne viruses, and people are screened about 85% of people actually uptake this opportunity to be screened, the patients on admission. They're screened for HIV, Hep B and Hep C. And Karen Macaulay, or Karen Burnett, she also educates people on hand hygiene, so it's obviously preventative measures, just like what we're supposed to be doing. So in terms of what the key issues are for us over the past year, when we look at our stats, 88% of our patients, I don't know how this compares with your own, are overweight or obese, and it's gradually been increasing. Now, there may be reasons for that increase, which I will explain to you. But when we look at our audits, look at an average 15% of this body weight is gained on the first year of admission, and that ranges between 20 and 57%. So that's really quite significant in your first year of admission to a high secure unit. So you'll be thinking, what are we doing to these people? What is happening? It's a bit of a scary figure. Now that's a little picture of the gym. We do have a lovely sports centre as part of the hospital. All the hubs that was mentioned were islands, and this one's a patient activity centre, which is a lovely big sports department. and it's called the Sky Centre. So this is embedded within the Sky Centre, this part here. But when we're looking at, again, back to our stats, the patients, only 14% meet the national recommended level of activity, and that's what's recommended for a healthy adult, is 30 minutes of activity 5 days a week. You could do a 15-minute walk in the afternoon, in the morning and the afternoon, so it's not huge amounts of activity, but only 14% of our patients actually reach that and achieve that. But we set local delivery targets to make it maybe a little bit more achievable, and 42% managed to hit that target of like 30 minutes 3 days a week, which, as I say, for a group that really are quite inactive, that was quite an achievement to get to that stage, because that has gradually increased over the last few years, so we're quite pleased about that. One of the big issues is the prevalence of diabetes, especially type 2 diabetes, again linked to the obesity. 19% this year, and so that's significantly higher than your national rate. And it has gradually been increasing, as I say, year upon year. Oops, sorry. We also have, this report was from Jill Murray and people from the physical health group. We've got 3% of people with ischemic heart disease, 27% are on statins now, because of the risks of ischemic heart disease, and we have 21 of our patients are diagnosed respiratory disease. I'm not painting a great picture here, but these are just actually the findings. So and the real issues with our patients. Plus COPD is a huge cause of morbidity, and it's because probably linked to the smoking histories of the patients within our unit. Now, trying to get people to this annual review is a real issue. We managed, there's only 28% declined this year, which is really good. It used to be the other way around. You don't get 20% attending. But over the years, people have really promoted and pushed and tried to encourage people to come for their annual physical health review. And we're only now getting to the point where like a third are declining it. So that for us is quite an achievement, believe it or not. We also had 25% of patients they participated in the bowel screen, which again was fairly good. Not as good as you would get when you were in the community service, but it's still really quite reasonable. And what we are seeing is problems with dental problems because of the consumption of fizzy drinks and sugary snacks, because people have access to all of these things within the hospital grounds. You can give them a decent diet, in terms of your breakfast, your lunch and your dinner and your evening meal, but people have access to other things that cause these issues, the wider problems. So one of the sort of main things I really wanted to go over was really look at what are the steps we have taken over the years to try and improve this situation, and what are the kind of current things we're doing. We have a dedicated physical health working group, and that's multidisciplinary in its focus. So there's a range of expertise there, and they help set local delivery targets, and things like 20% of patients in the healthy weight category is one example of something that they've set for this year. As I mentioned, the annual health check, we obviously try and push and drive people to attend that. Now, the healthy eating is a major issue, because our patients, they used to be allowed a takeaway once a week. Everybody was allowed that. Now that's changed recently to once a month. So each of the hubs are allowed in turn. They're allowed to get a takeaway. Now what I heard was they've tried to minimise what people are actually ordering for the takeaways, because they've minimised it to a starter, a main and a side. But the other day I was saying, what would be typically what people would order? And somebody said they would order double cheeseburger, 16-inch pizza and chips for one meal. So it's crazy. So that's why they reduced it to once a month as opposed to once a week. So even limiting it, people are still ordering these vast amounts of food. So we need to look at that and address it, I would say. Okay, the other thing was that what the hospital did try and do a while ago was try and minimise the foods that were available in the shop, the hospital shop in the Sky Centre. So, but one of the patients complained and went to court of session, and it was overturned. So we weren't allowed to stop and restrict the foods that we provide within the shop. What was it they actually said? It was said in the Daily Record, I think it was, it forced the eating policy, forced bosses to overturn the ban on chocolate and fizzy drinks. In a written ruling, Judge Lady Dorian criticised Carstairs for pushing through their health food policy with no consultation. So that was the reason that we weren't allowed to, because there hadn't been formal consultation with our patients. So the ruling was overturned. So now people can get whatever they want in that shop, adding to the food that they already get from their takeaways and from their regular meals. So it's a bit of a challenge that's been presented here. But we do have access to, people do have access to physical activity programmes, and there is a real drive at the minute to actively engage with the patients and actively encourage them. There's walking groups, there's a lot of different initiatives. And one of the, everybody within 42 days of admission, everybody's given a health induction. Now within each of the wards, there are physical equipment, see the bikes and their own equipment and things like that. Every hub has that. So if patients are too unwell to come off the ward and go to the Sky Centre, the Patient Activity Centre, then they can access these machines on the wards. They can go for walks with staff, they can do various exercises on ward and within their hubs. We also have outdoor gym equipment, so that in the summertime people can actually use that. It doesn't have the same level of resistance, so the patients are maybe less keen on them because they want to work a little bit harder, but they still have access to them. One of the sort of nicest things was, or one of the sort of promotional events that the sports activity team did recently was, you know how the Commonwealth Games were in Glasgow? Well, they had a Commonwealth Games for the patients in the hospital, and it was a full week of programme of activities. There's lots of sprint time, there was distance running, there was and the first afternoon there was the high jump, and I have to tell you this little story because this is it was probably one of the best afternoons I've spent in the hospital. They were doing the high jump, and there was this guy, we'll just call him Davy, right? Really super keen and super enthusiastic, but maybe not the best at the high jump. So he'd had 2 shots at the high jump, and now this high jump was a kind of cobbled together 2 badminton stands with, the tourniquets, a big string of tourniquets linked together, so it was kind of elasticy, but it wasn't a big bar that somebody was going to hurt themselves when they fell over, and the big crash mats. So picture the scene in a giant hall, probably a bit bigger than this, longer than this. So the bar was sort of maybe 2/3 down the hall. So he decided he was going to take a big run, and John says to him, "Are you ready now, Davy? Are you ready?" And Dave's going, yes, I'm ready. "Are you sure you're ready? Now take your time. This is your third shot. It's the last time. You've got to nail it this time." I'm going to do it. So Davy takes this almighty run and ran as fast as he could towards the jump, but he kind of half slipped, and he fell underneath the bar, fell in the crash mats, and he burst out laughing. And so of course there must have been about 50 people in the hall, and everybody was laughing with him, and honestly the atmosphere in the place was absolutely brilliant. People really enjoyed the events, and we weren't laughing at him, we were laughing with him, because it really was quite a spectacle to behold. But he got up and he did it the second. They gave him one more chance because that was accidental, and he managed it. And see the feeling, we had awards, and it was people had medals. They were on the podium. We were actually issuing the medals like you would at any other event, and the sense of achievement that the patients got from that was absolutely amazing. They said later on, when they reflected on it, they said it's the first time some of them have ever actually achieved anything positive in their lives, and actually gave them a real boost to their self-esteem and to their confidence. So engaging in these kind of physical activities and special events like this really can have quite an impact on people. So they will do things like that again next year, I have no doubt, but it'll be called something different. In terms of other areas and other pieces of work that we're involved in, the GP, Dr Jill Murray, has done some research into vitamin D. Subsequently, there was seen to be a gap, and quite a number of our patients are on vitamin D now. We also have online training programmes for our staff, for all staff, not just nursing staff, so that people can just to see what we should be doing and what we should be promoting. But obviously, there are some barriers, and we have to acknowledge that there are limitations as to what we can do, and acknowledge the barriers. People, in terms of the nature of the illness that people suffer from, maybe not always as motivated as other people would be to engage in physical activity, and they might not be ready to take that step. But there's also conflicting appointments with the other therapies, so we have to acknowledge that there are things that get in the way of trying to get people physically fit and healthy. We've also there's been quite a noticeable change in the population within the hospital. Within the last couple of years, there's a younger group coming through and presenting at the health centre, but with less chronic problems, not so much with asthma or COPD, but more with this type 2 diabetes. And what we have noticed is the people who have been educated in terms of the type 2 diabetes have actually acknowledged the need for lifestyle changes and a change in diet. So we're hoping over the next few years, then if we're presenting figures again, that they'll have reduced in terms of the level of obesity and value they place on people's physical health. There's also an issue with liver-related problems because the high incidence of alcohol abuse in the population, in the current population. The one thing I actually forgot to mention was the smoking, really. Smoking, we stopped people smoking 2 years ago, just a gradual sort of decrease. But within the forensic network, so we're in the high secure facility. When people get discharged and they move on to medium secure facility or low secure, then they can smoke in any of these facilities. But if they bounce back, then they've got to stop again when we get back into high secure. So there's a bit of an issue. It would be much better if it was a coordinated approach to some of these issues, especially in relation to smoking, because this can stop-start things, not ideal. But there are, across the forensic network, there are efforts being made to achieve the standard, as I mentioned earlier on about the Commitment 5, to have annual physical health checks. There are a lot of health promotional activities that go on, especially across Lanarkshire. The most recent one was, they do this annually. They had a kind of activity bus. Now that sounds a bit ridiculous, but that was just giving people information on all the different types of activities that they could engage in. They invited all the, not just all the staff, but relatives and friends to come up for a day, for a health promotion day. And so these kind of initiatives are really quite valuable. The patients absolutely loved it because they had an opportunity to have a shot at Reiki and some different alternative therapies as well, and yoga and these kind of things, as well as doing your sort of routine circuits. And I can't remember what the other sort of dance. There's a dance, keep fit dance thing as well. So that's just a wee kind of a flavour of what we've been doing in Scotland. So it was just I've got some references here, the main references that I was alluding to earlier on in terms of the physical health issues. I have just reported them here, so you can use these if you want or make reference to them. So thank you.